So we're going to discuss in this third session the best practice to use PRAC plenary time efficiently and effectively. I'm delighted to share this session with Margarida Guimarães. So Margarida holds an integrated master degree in pharmaceutical sciences and a post-graduation in pharmaceutical and medicine law. She joined Infarmed as a pharmacovigilance assessor and project manager in 2008. She is currently the Portuguese PRAC member and the coordinator of the the WP3 evaluation of the scope joint action.
So thank you, Vanessa, for the nice introduction. So basically, with this session, we want to present you with the PRAC Best Practice Guide on Efficiency. And the aim of this document was basically to help us prepare for the PRAC and for the busy meetings in a more efficient way. So I will hand over to Vanessa. She will present our colleague Geraldine Portier.
So I think you know Geraldine now, so I will not go back to her long experience at the PRAC Criteria. So the presentation now is the best practice guidance, what to know to optimize the preparation and the running of plenary meetings.
Thank you, Vanessa. So indeed, today the goal of the presentation is to present the best practice guidance on using PRAC plenary time efficiently and effectively, as Vanessa said. But just to give you a bit of background, everything actually started at the strategic review and learning meeting of the PRAC in Luxembourg. It was back in October 2015. At this meeting, the PRAC agreed that we would need on our 2016 PRAC work plan to establish a PRAC virtual group to make a recommendation on efficiency and effectiveness improvement for PRAC plenary meetings. So from this objective in the work plan, a small group of PRAC members and EMA colleagues started meeting by teleconference, having meetings by teleconference, and also meetings in the margin of the plenary meeting to agree on this on all these criteria. So now I will go through this. So the aim of this best practice guide on setting good principal rules is to optimize the preparation before PRAC plenary meetings, to also optimize the number of procedures discussed at PRAC plenary meetings. And this is based on risk-based criteria. So I will actually go through them later on. And I think it was mentioned several times during the previous presentation. So finally, you will know everything about this criteria. And the aim is also to optimize PRAC discussions and presentations delivered at PRAC plenary meetings. So the first part of this best practice guide, as I said, is named Optimizing Preparation Before PRAC plenary meetings. So what do we want? In terms of cover emails, well, when you circulate your assessment report, it's important to fulfill different criteria, because the early identification of issues or non-issues, if something needs to be discussed or not, really helps to better prepare PRAC delegates and overall the PRAC as a committee. So when preliminary assessment reports are circulated, in the cover emails, it is actually anticipated that the rapporteur team mentioned in their email if there is a need for plenary discussion, or if it is anticipated that a silent adoption will actually occur at the actual meeting. And again, this is based on the risk-based criteria, so I will explain again after this. So ideally, you can put it in the core of your email, But even better, you could even include this in the subject of your email. Now, when you circulate the updated assessment report, so you have integrated all the comments received from the other delegations. In the email, we really need to have the final statement on the need or not for plenary discussion. So at this stage, we really expect to get this information systematically, because indeed, at the time of the preliminary assessment report, it's difficult to anticipate the comments you will get. But sometimes you also know that the issue is low profile, so it's unlikely to go for plenary discussion. So if you know it, include it. Otherwise, you keep silent on these aspects. But really, at the time of the updated assessment report, we really expect the different delegations to mention it. And the same rules. If you can also include it in the subject of your email, that would be great. So, how do we use it as a PRAC Secretariat? In the first time schedule that is circulated the Wednesday prior to the plenary meeting, we use this information to build the order of topics. When the topic has been confirmed for plenary discussion, it will appear in white, well, black, but on a white background. If we haven't received any information yet, so there may be different situations, because unfortunately there is no information in the email nor on the cover page actually of the assessment report, where now it becomes more and more systematic that you have to tick a box, but again, include it also in your cover email. But if we don't have this information there, or if the updated assessment report has not been circulated yet, we mention these topics gray shaded. So you may have seen already on the Thursday when you arrive at work before the PRAC plenary meeting that the time schedule is actually very long, but there are lots of procedures that are gray shaded. And usually it prompts the different delegations to provide us the final position based on the risk-based criteria on plenary versus silent adoption. But to go back to the cover emails, if there is a need to discuss the content of a DHPC, or actually to discuss the need for a DHPC, we would recommend that you mention it very clearly in your cover email. And for complicated issues, we really expect the delegations to include a short paragraph in that cover email describing the issue. So it can be quite short, a couple of lines, but I think it helps all delegations and PRAC Secretariat plus EMA colleagues involved in PRAC activities to focus on the main issues. And a few delegations are also using a reader's guidance, which is a short document, separate document, where all this information is included. And this is really appreciated as far as we know. Also, when the issue is very complicated or controversial, we really recommend to organize a separate discussion with the rapporteur, EMA, chair and vice chair when it is needed, and relevant members. This meeting can be organized with the help of the EMA product or procedure team in advance of the plenary discussion. So ideally, a few working days before the start of the meeting, don't hesitate to request your EMA colleagues to facilitate the potential short teleconference, or put in contact in an email all the relevant people, so that we can have a more efficient discussion at the level of the plenary meeting. Next slide. Now, we have also included here some aspects that needs to be taken into consideration. In terms of written comments, we really encourage all delegations to circulate such comments. Why? Because, again, it really helps to give a direction where the discussion will go towards to. And this is particularly important for referral procedures. I think it was developed in details earlier in the presentation on in the presentations on referrals, but really for for very complex procedures, it's very difficult to arrive at the meeting without knowing if the committee as a whole will support a variation, a suspension, a revocation. I think this is really important. So a comment, by the way, can be also, I agree with the rapporteur, or I have no comments. This is also helpful and valuable. Now, another point, the cutoff date to include new topics. I think it was mentioned also in previous presentations, but the agenda is actually closing on the Tuesday, the week preceding the PRAC meeting. What does it mean? If you want to ask, if you want to put a member state request for PRAC advice, for example, but it can be also that you have spotted that a procedure was missing on the agenda, we expect you to come back to us by Tuesday. So we can correct it, and it's actually help the PRAC to understand the extent of the agenda and actually what is going to be discussed during the actual plenary meeting well in advance. I think it's not efficient at all to be made aware on Monday morning or actually on Tuesday, oh, we forgot the procedure. This, we really want to avoid this situation because it's stressful for everybody, and of course, nobody is well prepared in such situation. So we count on your support as well. Now, in terms of PRAC agenda, we also encourage every delegation to check the different versions that are circulated. So as you know, we circulate revision 0, 1, 2, 3 in advance of the meeting. And the earlier, the better. So as I was saying, please do not hesitate to flag any missing procedures or mistake, or even, if you have any doubt on a procedure, do not hesitate to email us. We will be very happy to come back to you. In terms of OGAM topics, the rule is the same. Usually they mainly come from EMA, but we have some exceptions where the PRAC delegations are putting requests. We have also a form for it, and we also expect to get it before Tuesday, before PRAC. So this is the request. Now, in terms of documents and presentations, if at all possible, that would be great that they are made available in MMD, so the system where we share documents and presentations with the network. We would like to get them at least 4 working days prior to the PRAC plenary meetings, or when it applies before the ORGAM teleconference. So just maybe to make it clear, ideally, we would like to discuss all topics on the PRAC agenda for discussion during the plenary meeting. Unfortunately, there are sometimes some priorities, like in 10 days at PRAC, there will be several referrals discussed. So, to be honest, it's probably unlikely that PRAC will manage to discuss all the ORGAM topics. So, as a backup system, we organize a teleconference 15 days later. So it's basically the Thursday, it coincides with the Thursday of the CHMP. And at that time, we will cover the remaining ORGAM topics. So as I was saying, at least 4 working days before, we want to have the documents and presentation in the system. So either before the plenary meetings or that ORGAM teleconference. Now, I go back to the preparation before the PRAC plenary. For the PRAC minutes, well, in principle, we circulate them in advance of the meeting. Unfortunately, it's difficult to circulate them well in advance. However, if we could, at the time of the adoption at the plenary meeting, reduce the comments and clarifications during the plenary meeting, it's important that delegates provide also comments in writing. Usually the comments come from the member or the alternate. Rapporteurs will mainly comment on their procedures. But this is very helpful because then it makes also the review of the minutes and their adoption faster. Now, I think if we move to the next slide, we actually tackling the second section of the best practice guidance. which is entitled Optimizing the Number of Procedures Discussed at the Plenary Meeting. And here are the infamous risk-based criteria for plenary discussion. So we've tried to capture everything here on the slides by means of a table to make it clearer to all of you. But for referrals, all referrals, we always go for discussion and all steps. So start and list of outstanding issues and recommendation, of course. Now, in terms of signals, we have to distinguish the new signals from the signal follow-up. These are, by the way, captured in our agenda under section 4, the signals, while referrals are 2 and 3. So back to signals. When we have a new signal, we expect that every recommendation, because as you know, each time it's discussed at PRAC, it's a recommendation. So even if there is a signal follow-up, it will be a further recommendation. But basically, or I should actually start by the silent adoption. We are at the moment trying a pilot. And if you have a signal that follow where the draft recommendation from the PRAC delegation is a cumulative review following a standard 60-day timetable for the MH to respond and a 60-day timetable for the rapporteur to assess the data, or if the recommendation is actually a cumulative review requested within the next PSUR. So in the next submission, basically, the MH will be requested to provide this data. If the DLP data log point is within 3 months, and also there is no disagreement between member states, this could qualify for silent adoption. But please always liaise with your signal management lead colleague, so you will have one allocated to your procedure. In principle, we expect that you are exchanging emails with them, but otherwise we include the name of this person on the agenda, and you can agree on a silent adoption or not. And basically, all the other scenarios will qualify for plenary discussion. So what we can see is like a non-standard timed cumulative review, if there is a need for new study data, or if actually it starts with one substance and considerations are given to extend to a class, or in fact, if the initial signal is also on a class of products, we expect them to come for plenary discussion. And of course, if there is any disagreement between member states, or if a member state or the chair or any member requests to have it for discussion, it will automatically qualify for plenary discussion. Now, for signal follow-up, all of them go for plenary discussion. When a signal follow-up is actually assessed within a PSUR or PSUSA, it will need to use the criteria for PSUSA that I will actually explain right now because it's on the next slide. So PSUR, you will find them on the PRAC agenda under section 6. So 6.1 are PSUSA for CAPS only, 6.2 for CAPS and NAPS, and 6.3 for NAPS only. And the criteria are the same. So there are any draft recommendations, so coming from the PRAC delegation of the rapporteur, recommending a revocation, suspension, or variation, it will always qualify for plenary discussion. Now, for maintenance, well, there are some distinctions to take into consideration. But if there are any divergency between member states, if the MH is not in agreement with the rapporteur recommendation, if there is a need for additional pharmacovigilance activities, risk minimization measures, or update on important pharmacovigilance activities, yes, sorry, I already said it. If there is a need also to request supplementary information before the next PSUR, meaning that if you are on a very short frequency, please always consider requesting this data in the next PSUR. But if we are, and this is actually valid for PSUSA for CAPS, if you consider that the data are very useful and needed earlier, this would actually qualify for plenary discussion. because the committee will need to consider what is the best way to handle this data. And of course, there can be also other issues discussed in parallel at PRAC with potential impact on the recommendation. And finally, it's the same as usual, actually, for any procedures. It can be requested at any time by the PRAC rapporteur if it's of interest, or if there are some disagreements, again, don't hesitate. Otherwise, if it's a maintenance, so actually many PSURs go for maintenance, there will be a need for some cumulative review in the next PSUR. Let's say they are very standard and also low profile for the committee. So these can qualify for a silent adoption. Now, you may have noticed on our agenda, we have a section under 6.4, which is called PSUR follow-up. So this is only for centrally authorized products, but this is what we call the legs, infamous legs. So these are post-authorization measures, and it's when, after in the recommendation of PSUSA, PRAC recommended to get some further information before the next PSUR. So that's the scenario I was describing earlier. And in that case, these data are going to be further assessed by the PRAC. And the criteria for plenary discussion will be if there is a divergence between member states, and again, at the request of the PRAC rapporteur or any member or the chair, if there is a need to highlight any issues. All other cases, we expect the procedures to go silent. Now, if we go to the next slide, RMPs. So RMPs on the PRAC agenda are captured under section 5. So 5.1 is dedicated to procedures in pre-authorization phase. So all initials, but only for initials applying for under the under the centrally procedure. Sorry. And 5.2 and 5.3 are for post-authorizations procedure. So for the pre-authorization phase, all procedures that are reaching D180 at CHMP, so what we call at PRAC pre-D180, but it's obviously 15 days earlier, all these procedures will qualify for plenary discussion. And with some exception for generics. And for generics is because because basically the applicant is fully aligned with the originator. There is also another case in I go back to an earlier phase, but pre-D120. Actually, these procedures are not even captured on the PRAC agenda, but there is an exception for any ATMPs, so advanced therapy medicinal products, PUMA, and also accelerated assessment. These procedures are always on the PRAC agenda. There will be a PRAC outcome, and they will go automatically for discussion. Now, as I was saying, all the other cases will go silent. Now, if we talk about the last phase of the procedure, so just before opinion at CHMP, these procedures won't appear on the PRAC agenda. This was agreed a couple of years ago when there was the revised RMP process in initials. But there is an exception. The CHMP and PRAC chairs can be consulted to agree on exceptional cases to go for a plenary discussion at that phase. So please, if there are some major pharmacovigilance or risk minimization measures that are agreed in the last steps of the procedure, please consider to involve the PRAC, but it will be only on request. Now, if I move to the post-authorization procedures, well, in fact, most of them go for silent adoption, but there is some exception. So if there is an issue that might have an impact on imposed conditions, if there is an introduction of changes to risk minimization measures, and also if there are some, as usual, substantial disagreement between rapporteurs and PRAC members, and also at the request, upon request, basically. As I said, these procedures are usually for silent adoption, So as you will see in the minutes, we only have a very small subset of procedures from section 5.2 and 5.3 that went for discussion. Now, moving to the next slide. Passes. So under the remit of the PRAC has a remit to discuss the imposed non-interventional pass. And the legislation is very detailed in that way. So there are dedicated procedures for this. And there are the protocols. And you have also the results. So in terms of protocols, they will be always discussed in the first round. But it will go for silent adoption after the first round, unless there are some substantial deviations from the imposed conditions proposed by the MH, or recommendation of rejection, final outcome by the PRAC rapporteur, substantial concerns from PRAC members about the design or feasibility of the study, or substantial disagreement between PRAC RAP members, and as usual also upon request. Now, in terms of results, this is actually something quite new for PRAC. Tomorrow you will have a session on imposed pass results to describe the procedures and also good practice and good examples. But at the moment, as it is new, we expect they always come to PRAC for discussion. And we could go for silent adoption if it's agreed as such. So now if we move to the next line, there is also another section on the PRAC agenda, so it's also under section 7 on the non-imposed, non-interventional passes. So in that case, we distinguish the protocols, the pass results, but also interim results. So in terms of protocol, we actually don't expect them to come for a discussion unless there are further regulatory actions proposed, so SMPC update or additional risk minimization measures, and or, as usual, the substantial disagreement or upon request. The interim results are actually also qualify for plenary discussion if there are major issues with the feasibility of the study, and or further regulatory actions are recommended already at the stage of the interim results, and again, if there are disagreements or if it is requested. If I go to the results, again, we don't expect discussion unless further regulatory actions are recommended and or substantial disagreement between RAP and members, and also upon request. This you will note, by the way, that the past results here are actually submitted via variations under type 2 variation C113 to distinguish clearly from the imposed past results that will be presented tomorrow. Otherwise, all the other cases, actually, we expect them to come routinely silent. Now, Section 8 of the PRAC agenda is on renewals, 5-year renewals, conditional renewals, and also annual reassessment. So when do we expect to have plenary discussion? Well, when there is a negative, the rapporteur considers that the benefit risk is negative based on pharmacovigilance grounds. If there is a need to impose some pass resulting from the assessment of this renewal, and again, if there are some divergent positions or proposal for an additional renewal based on pharmacovigilance grounds, and again on request. For the conditional renewal and annual reassessment, we expect the delegations to propose a plenary discussion if interim results of the specific obligations are non-interventional pass challenging the benefits risk of the products, if new imposed pass resulting from the renewal assessment are proposed, and again, if there are some divergent position upon request and proposal for an additional renewal. So all the other cases would go for silent adoption, and I think these procedures are actually rarely discussed at PRAC. They go mainly for silent adoption, but still, when they come, usually it's for a quite serious issue, so they may deserve a good slot for discussion. Now, that was a bit long, and of course, it was maybe not very digest, but you will find this information again on the slides and in the best practice guide, so please refer to it anytime, or you can ask questions to PRAC Secretariat as needed. Now I would like actually to move to the last section of our best practice guide, which is entitled Optimizing PRAC Discussions and Presentations. So of course, the preparation is very important, but the actual discussions at the committee level very rely also on good presentations, because I think it will really focus on the discussion after presentation and will help to reach faster and a better conclusion. So just to give you an idea of the time schedule, but I think it was already mentioned in Vanessa's presentation. But usually how we deal with the time schedule, on the Monday, if we have referrals, they will be given the priority. So usually they're discussed on Monday. And of course, if there are requests for oral explanations, ideally they come on Monday. But if we have many oral explanations, they could be also on Tuesday morning. And as a priority, we also discuss the member states and CHMP requests for PRAC advice. And by the way, I didn't mention it, but they always come for plenary discussion. On the Tuesday, as I said, if we have further referrals, they will be discussed. And it's followed by PSURs and passes, so protocols, results, or interim results. If we have a public hearing, it will happen ideally in the afternoon of the second day of the PRAC. But as it was said earlier, so far we haven't had any. On the Wednesday, PRAC usually discuss signals, RMPs, come back to referrals because it's rare that it's a one-off discussion. So usually they're discussed on Wednesday, and we also try to tackle some organ topics. Thursday, we have inspections topics. So this falls actually under section 9 of the PRAC agenda. We usually don't have many topics, and they always come for plenary discussion. I forgot to mention it. But the Thursday will be also followed by what we call the wrap-up. So is to summarize all the important decisions and make sure that it is what the PRAC is adopting. And also we discuss some PRAC discuss some organ topics. And well, the last day, if one day we have a public hearing, the PRAC will last until Friday, and basically all the discussions that were scheduled the other days will be taken a bit later because of the public hearing. So now, next slide. In terms of discussion. So as I said earlier, most time is dedicated actually to the issues of greatest public health importance. It's important to streamline this discussion and use the time efficiently. So it's very important to tailor the presentations, of course, to the complexity of the issue. It's important to focus on the controversial points and what is the decision that PRAC needs to take, and also to summarize the discussion points. A slide on summarizing where we are after presenting the different slides usually is a good aid for the committee to have a structured discussion. Of course, if time allows, it's good to take the time to discuss them, but unfortunately we have plenty of topics for discussion. So if we start lacking some time, this is more for PRAC members and delegates. Everybody should be able to make a critical assessment of the presentation and focus only on the main points. I think most of the assessors are involved in preparing the slides, so I think it's a very important point to make the PRAC plenary, PRAC plenary meeting efficient. So anyway, again, this is more for the PRAC members, but to keep the number of intervention only to the minimum and concise, and also avoid to reopen some issues. So let's go to the next slide. A few tips. So depending on the nature and complexity of procedures, the size of your presentation may vary enormously. We actually expect usually that the referrals followed by PSUR, RMPs, signal follow-up, and initial signals will basically be the first one, the biggest presentation, and the last one, the smallest ones. So basically just to say that referrals may frequently justify more than 10 slides, 15 minutes presentation, while PSUR's RMP could probably be fitted only in 5-10 minutes. Initial signals most of the time require just a couple of slides. And actually for the straightforward ones, sometimes the rapporteurs request to only have the recommendation on screen. So presentation, just a basic introduction and background. No need usually to provide all the details and data of the discussion from the assessment report, and just to focus on controversial points. You can also consider including backup slides that may be used during the discussion, and use only tables and figures that can be seen at distance, because it's like here, the PRAC plenary room, we have only big screens, so if it's too small, nobody can read. Next slide. So now, very quickly, because actually my presentation is starting to be not very efficient, it's a bit long. We have another document that PRAC adopted in June on the implementation plan and goals. I actually won't go too much into details, but it's just to show you what type of data we are collecting. We have qualitative goals. Maybe I don't need to go through them, because this is an exercise which is a more a long-term exercise, and we have started to collect some quantitative goals. So the first one is to measure what time the PRAC is finishing on Mondays, Tuesdays, and oops, sorry, there is a typo here. It should read Wednesday, so we will actually correct it in the final package of presentation. And the quantitative goal 2 is to try, when possible, to finish by 2 p.m. on Thursdays. So as I said earlier, good preparation and good presentations really help to reach this target. I won't present this. It was actually presented for the first time at the ORGAM meeting, the last ORGAM meeting that we had around last week, 10 days ago. So you can read them, but it's the measures that the PRAC Secretariat is doing, and we'll present to PRAC every 3 months. And at the moment, because it's the first measure, it's difficult to make comparisons, but I think on the long term, it will be a useful information. So if we go to the next slide, we also actually collect some metrics on referrals. I won't go into details because this was also presented during the session on referrals, but feel free to read them. And last quantitative goal is less than 5% of the items on the time schedule. Revision 0 should not more than 5% should be gray. So as I mentioned, where we don't have any information on silent versus non-silent. So please have a look. We have collected this information for July, September, October on the different revisions. So if we go to the next one, and per type of procedure. So next. Voila, so I mentioned it, our timelines to collect qualitative goals. So there will be a short survey that will come in April, May. And the quantitative goal, as I said, was just are collected on a 3 months, quarterly, sorry. So if we go to the next slide, I think that's nearly the final one. But the best practice guidance and the implementation plan and goals are available in MMD. So anybody who has access to MMD can retrieve these documents at any time. So please do so. And if we go, it's just to thank you for your attention, and apology actually for being slightly long, but I promise I will be very efficient next time.
So thank you, Geraldine. It was actually quite detailed, but I think it's very useful for everyone to see what's the criteria for discussions. Geraldine provided some very nice tips for the presentations as well. So go through them, and we will have the Q&A after this session. So I'm going to present my colleague Anna. Anna has a degree in pharmaceutical sciences and has also a master degree in herbal products. She has been a pharmacovigilance assessor in Infarmed for more than 2 years now, and she's also our backup quality manager. And she's also a quality auditor. So you have here a multitasking person who will be presenting on our Portuguese experience on how to prepare for the PRAC, and she will give you some very nice practical examples. So Anna.
Thank you, Margarida, for your introduction, and I will also like to thank the EMA for the invitation. And basically, I'm going to explain you how this practice guidance can be used in your daily work. So I'm going to show you how we do it in Portugal, how we prepare the meetings with concerning our procedures, the written comments we provide, how we check the PRAC agenda, and during the meeting, how we need to focus not only in our presentations, but also the other procedures that are going to be discussed. So it's very important to plan your workload. You need to be aware of the ongoing procedures, because there might be coincident timelines, and you also need to be aware when when to provide comments. And it's very important to also be aware that there are different parties involved, and in our case, our pharmacovigilance team, we have pharmacovigilance assessors, clinical assessors, and also the PRAC delegates. And we also try always to have a mutual approach between the three committees, the PRAC team and the CMDH team and the CHMP team. And for that, we have internal meetings, as Margarida has explained before and after each committee team, to prepare that meeting and also to give feedback to the other committees of what happened during the meeting. So when we talk about the planning and organization, we need to be aware of how many procedures and what procedures we have at each time. So I'll show you this example. It happened this summer, in the last week of June and beginning of July. We had to have 6 assessment reports ready to circulate during that week. So we need to plan and do the organization to guarantee that the clinical assessor has enough time to look at the documentation and to do the assessment report, and we also give our input. And this needs all to be ready so that the PRAC member looks at the report and gives her feedback in order to circulate the assessment report at the defined day, because we try to circulate the reports in time to guarantee that other member states have enough time to comment if they want to. Of course, it's also important to know what other ongoing procedures we have, if we are a rapporteur for them, because we need to concern with them also, and we need to provide comments to other procedures. We need to know if there are any other safety-related issues, and we also have other pharmacovigilance activities. So we need to coordinate very well. And so it's very important to gather the best team as soon as possible. And the pharmacovigilance assessor needs to have experience in the pharmacotherapeutic class, and that's how we work in Portugal. We are divided by pharmacotherapeutic classes. And when we choose the clinical assessor, we need to consider his expertise, his clinical experience, and also the experience in drafting assessment reports and in the relevant scientific area. And we also have the PRAC member. And it's important to guarantee that each one of them need to consider the other ongoing procedures they are responsible for. So it's crucial to guarantee their availability and their commitment. We also need to look at timelines, and we know that EMA timetables are defined in an early stage, but we need to consider that they can be updated. So it's important to consider your own timetable and share it with your team and stick to it. And sometimes it's important to consider interim meetings before circulating assessment reports and providing comments, because major issues might be raised. And what we do in Portugal is we look at the URD list, the EMA timetables, and CIAMED NCA dashboard, and the CHMP summary of outcomes. And we have an internal document with the timetables of all the procedures for which we are responsible for. So we know exactly what we need to do and when we need to do it. Of course, we are not machines, and we don't remember this, and we are not looking at the document all the time. So we have Outlook reminders to know the most important dates. And this document is updated as whenever it's necessary. So we just don't do our assessment reports. We also provide comments to the other procedures, because we consider it's an important contribution to the quality and consistency of other assessment reports, and it will also facilitate the planning and the discussion at the meeting. And it also helps the preparation of all PRAC delegates, because by providing our comments, we can show what is our point of view about that procedure. So we always send comments to the procedures in which we are co-rapporteur and to the referrals. And in the other procedures, it will be a case-by-case approach. We have an internal document that we have created with some criteria defined by us to know when and to what procedures we should focus the most and provide comments. For example, in the PSUSAs, we need to look if a centralized product is involved only, or if we have national products. If the recommendation is for variation, suspension, or revocation, or it's only for maintenance. And if there are any requests for information or to change the PSUR cycle. And another criteria that is very important is if the product is authorized in our country, because then we have an additional responsibility. So we also need to know when we are going to provide those comments in order to be organized. So for the example of the PSUSAs, we know, according to the EMA timetable, we know that in that exactly day, sometimes it's not that day, but a few days before or a few days later, we are going to receive, the assessment reports are going to be uploaded in the PSUR repository. So we have Outlook reminders to check the repository at that day. And during that week, we share an internal email between the pharmacovigilance assessors and our PRAC delegates. Each pharmacovigilance assessor sends an email with the PSUSAs he is responsible for, according to our division in pharmacotherapeutic classes. And considering the criteria to provide comments, we say how many PSUSAs we are going to comment, in order to guarantee that all the team is prepared. And we avoid to prepare those comments during the PRAC meeting, because our members need to be focused on the meeting, and they may also need our input during the meeting. So we try to send those comments and to prepare them before. This will all help the preparation of the meeting, but it's also very important, considering our procedures, to share the information about the procedure is going to be adopted to plenary discussion or by silent adoption. So we share that information with other member states when we circulate our final assessment report. We have an internal document with the agreed risk-based criteria for adoption with or without plenary discussion. So we can look at it whenever it's necessary, because we don't, as I said before, we are not machines. We don't need to know those criteria. And so we can easily look at documents and to know if it's necessary to have a discussion or not. And additional, and to help our work We have templates for the cover emails with both sentences, so we can choose if it's for plenary discussion or if it is for silent adoption. It's just to facilitate our work. Another thing that we do is that we check all versions of the PRAC agenda, and whenever it's necessary, we send comments. I'll give you this example of the last meeting, of the PRAC last meeting. We had a topic that was suggested for a plenary discussion. However, we have uploaded an amended assessment report, and so the recommendation was no longer for variation, but for maintenance. So we suggested that the procedure was adopted by silent adoption, because we consider it is important to avoid unnecessary plenary discussions and make sure that the time during the meetings are dedicated to the most relevant issues. And during the meeting, we need to consider not only our presentations. In Portugal, most of the time the presentations are made by the members, the PRAC member and by the PRAC delegates, but it's important to help them whenever it's necessary. That is why it's also important to prepare them for the other procedures that are going to be discussed. And so that is why we try to provide the comments as soon as possible, and we do it before the meeting whenever it's possible. And in the March meeting, for example, we had 2 topics that were going to be presented, but we have already sent 43 comments to other procedures. However, even with this so much big input, we consider, sometimes it's necessary to have an additional input during the meeting. I just want to highlight that we don't send comments because we like to do it. It's because we consider it's important for the reasons I have explained earlier. So as I said, during the meeting, sometimes it's necessary to have an additional input. In that meeting, it was necessary. We have sent comments to a past protocol on thiocolchicosids, about questioning about the survey that was being proposed and the access to databases, because the one marketing authorization holder said there was no databases in Portugal, and also about the time frames that were being proposed. We had some concerns about the approval and distribution of the educational materials in Portugal, because they were not distributed yet. And so it was necessary during that week to coordinate with other departments in our agency, because there was a renewal that was under assessment for one product. And so since it was necessary to update the product information, we could not distribute educational materials before that information has been updated. And also we had to coordinate with other departments about the access to a prescription database that existed, and however the MA did not say that. So it's very important to be prepared, because your input might be necessary during that week. So what I hope I have explained you in a very, very fast way is that you need to be prepared, plan your workload, define your own timetables, and use and abuse of reminders. It's very important to provide comments in an early stage. In order to optimize the number of procedures that are going to be discussed, you need to be aware of the risk-based criteria. You should include the information about the need for discussion when you are sending your assessment reports. And you should also check all topics on the PRAC agenda. And if it's necessary, you should provide your comments. During the meetings, the presentations are very important, but you also need to be aware of the other procedures. So it's very important to provide your comments, and if possible, you should do it before. And you should be aware that additional input might be necessary. So the whole team should be available. And of course, you must not forget that you all I think you all, also have other pharmacovigilance activities. So it's very important the planning, organization, and teamwork. Thank you.
So thank you, Anna, for the nice presentation. I just wanted to highlight that these two presentations are very important for you to understand there is a big machine behind the PRAC. It's not only the plenary discussions. I think the plenary meeting is like 1/10 of our work in the PRAC. We have, thank God, a fabulous secretariat. These are super ladies that help us organize and are always available for us. They work late hours to answer all the silly questions we have. And it's also important to have a good team back at home, an organized team, even if it's two people. Like in some member states, I know from my colleagues that they have like 2-3 people working in pharmacovigilance to do everything. So I think it's even more impressive. But I think our point here is to try to organize and in order to make our work more efficient and as an outcome, of course, the PRAC plenary meetings to be more efficient. So does anyone have any questions for the colleagues that presented, both Geraldine and Anna? Yes, Alexander.
Thank you, Geraldine, for your presentation. Very informative to know how to present and how things are going on at PRAC. I think it's very good to know. I have 2 questions. I'll be boring. I will be asked about my subject tomorrow. So, regarding post-authorization safety studies, you said that the protocol it's discussed only if there are questions or if there are major issue to be debated. After the first round, I mean. So the protocol, the assessment of the protocol of past studies is discussed first, and then only if there are problems, right?
Yes, no, that's correct. I was just checking this scenario, but indeed, if the PRAC rapporteur delegation is actually going recommending a rejection of the protocol, this would definitely qualify for a PRAC discussion. Or if there are some concerns about still concerns on the design or feasibility, or again the 2 criteria that are actually valid for any procedures is substantial disagreement between rapporteurs and members, or if someone considers it's important to bring it to the attention of the committee.
Okay, then you already answered my question before saying it. Thank you, because that was my question. Where is the threshold for discussing a second time? Because sometimes we have ongoing debates, and I don't know what the threshold for discussing a PRAC. But a rejection or something really serious. So, okay. And
just maybe to mention, all these procedures actually also have colleagues, internal colleagues, supporting the assessment team. So also don't hesitate to refer to them. In particular, the team taking care of the imposed past protocols and results. They're very specialized and experienced in this field, and they can really also help to guide if it's a plenary or silent adoption. So of course, I mean, if you're a delegation dealing with lots of procedures, probably you don't need to ask the questions, but for smaller delegations, I mean, there is no silly questions, and they should not hesitate to ask PRAC Secretariat or their EMA contact, if there is a doubt.
Thank you. And I have a second question also about past studies, this time the results. So, as you know probably better than me, for Diane 35, we had several rounds of questions to the marketing authorization holders. And, well, I know you already said that it's a new procedure, and we know that. But how does it go when you have several rounds? So you assess the final study results, and then maybe you need several clarification from the marketing authorization holder. Is this in place, or it's more or less
No, the procedure actually is going to be described in details tomorrow, so I would prefer my colleagues to explain this to all participants. But indeed, each time it will come back. At the moment, it will go for a plenary discussion. So, and each
What
time
happened
there
in
is a
our
round.
case, yeah, but I was wondering if there is any rule about it, but not yet because it's the new. Okay.
No, at the moment we just decided that it will always come because first we only have a few examples. So I think it's important that the committee feels comfortable before setting up some further rules. Yeah.
Thank you.
Any more questions? It was a long day, maybe.
Actually, I have one question. I was wondering if this best practice guidance is circulated in your agency, shared with your colleagues, assessors, because I think it's an important document, and based on the example from Portugal, I think it's also important to have some internal guidance also for your coordinators and assessors. Yeah, so just a question if you have such initiative at your NCA. I mean, if anybody wants to comment, you're not obliged. Huh? Yes, Jane?
Yes, it was circulated to us, and we had what we call a kind of best practice meeting to discuss it with our PRAC delegate. So he went through it and explained all the new procedures and criteria and thresholds. So.
So yeah, just to clarify, because Anna talked about our internal document, but obviously our document was based on the criteria that was established in the best practice guide, of course. So we do have internal criteria, but it's based on the overall criteria. So if there are no further questions, we understand it was a long day. And we are obviously available if during the evening or you have nightmares about the session. If you have something you want to ask us, we are obviously available for you. So thank you very much for joining today, and we hope tomorrow will be a very nice day as well. So thank you.